Mm.
Good evening, respected professors and Professor Madam, and my dear students. I welcome you all to today's session of V30 academic activities on WebEx platform. Today we have MEOR students presenting three important pediatric topics, followed by, if time permits, we'll have some ASCII discussions with professors. Over to Dr. Vidya Elumalai. She'll be presenting a topic on 6 months old male child, recently recovered from LRI 1 week back, being posted for circumcision. Dr. Vidya, please.
Yes, sir. Sir, good evening.
Good evening.
Uh, Sir, according to the period complication is increased in between 2 to 6 weeks of lower respiratory tract infection, and airway reactivity is increased 6 to 8 weeks of post lower respiratory tract infection, sir. And anesthetic concerns in this child is, since it is a pediatric population, separation anxiety, difficult airway, both physiological and anatomical, difficult IV access, and risk of hypothermia. And top of it, post LRI, there will be increased risk of increased secretion, decreased airway caliber, increased incidence of laryngospasm, bronchospasm, breath holding, increased episodes of desaturation, atelectasis, increased apnea, stridor, coughing, and there is increased incidence of post-op pneumonia, unanticipated tracheal intubation and re-intubations. Risk predictors are patient with active respiratory tract infection, nasal congestion, purulent rhinorrhea, productive cough, and history of passive smoking. Premature baby born less than 37 weeks, history of reactive airway diseases like asthma, and history of snoring, patient confirming that the child has cough and cold. What recommendation says is, if the child is with active respiratory tract infection and if it is the elective procedure, we should postpone the procedure for 4 to 6 weeks. But we have to individualize it according to the patient and the procedure and the anesthetist competence. Since it is a minor daycare procedure, after confirming that the patient has only a mild symptoms and the baby has no purulent rhinorrhea, any lung signs or active infection, fever, if the patient baby has only mild rhinorrhea, we can proceed with the surgery, avoiding endotracheal intubation. GA with spontaneous ventilation, preferably face mask or LMA, along with caudal block or penile block or ring blocks. So our goals are to minimize secretion, minimize airway manipulation, choice of airway devices in the order of face mask, then LMA, then endotracheal tube, anesthetic agents preferably propofol than thiopentone, and sevoflurane than isoflurane. We have to do smooth induction and smooth awakening.
So that's you have somewhat present or you have completed? You have already completed all that anesthetic technique also.
Sir, pre-op assessment and interop strategies.
Okay.
So preoperatively, we have to take a detailed history of duration of illness associated with fever or not, nature of the nasal discharge, whether it is purulent or watery, nature of cough, whether it is productive, and history of previous nebulization. And we should examine the throat thoroughly and look for any lung signs. And we have to auscultate the lung to look for any wheeze. We have to document the vitals, temperature, and any presence of active symptoms of respiratory tract infection. And we can add on to it, we can have a laboratory parameter like CBC to look for the WBC count and X-ray if required. Preoperatively, we have to continue the corticosteroid and the bronchodilators. Preferably, it can be given 10 to 30 minutes prior to induction. So, intraoperatively, equipment for standard intubation, difficult airway, 1 to 2 sizes of smaller than the predicted ET tube size. A working suction port should be ready. Optimal OT temperature, forced air warmer, and warming mattress to prevent hypothermia. Nebulizing equipments, corticosteroid and bronchodilators should be kept. IV line is must. Monitors should include pulse oximetry and capnography. IV induction is preferred than inhalational induction, but sometimes we need to give GA with spontaneous ventilation to secure an IV access. Then we can induce it with propofol 2 mg per kg IV. Injections Xylocard 1.5 mg per kg to reduce spasm, or the LMA should be lubricated with the lignocaine jelly. We have to maintain adequate depth, good humidification, and then we can proceed with caudal or pineal block. We have to maintain adequate hydration. Injection dexamethasone 1 mg per kg IV is to reduce post-op swelling, airway edema, nausea, and vomiting. So we have to do suctioning only in the deeper planes, avoid suctioning in the lighter planes to prevent reactive airway constriction. Extubation and post-op analgesia. We have to extubate after complete awakening or in deeper planes. We should not attempt extubation in lighter planes. We have to continue post-op monitoring, post-op nebulization with bronchodilator and corticosteroids. Use of NSH is controversial since the baby has a respiratory tract infection. So preferred is paracetamol suppository 20 to 30 milligram per kg per rectal. And then we have to advise the parents to apply topical lignocaine jelly regularly. Thank you, sir.
Okay. Is there any role for ketamine?
Yes, sir.
What way ketamine is a preferred drug in the pediatric patients?
It causes bronchodilation and it protects the airways. It protects the patency of the airways.
Will it not cause an increase in secretion?
Yes, sir.
That may stimulate a laryngospasm.
Yes, sir.
So how to manage that?
We can give pre-medication with anticholinergic like atropine.
Atropine. Can atropine and ketamine be combined together?
No, sir. We usually
Why?
combine ketamine with glyco.
Why
Ketamine with
ketamine and atropine?
glycopyrrolate.
What will happen if you combine both? What is the effect of ketamine on heart rate and what is the effect of
Tachycardia.
atropine on heart rate?
Both will cause tachycardia.
Symptomatic.
So both increase the heart rate, isn't it?
Yes,
So
sir.
it's not preferable to add atropine to ketamine. But as Risha said, you can add glycopyrrolate to ketamine, and the action of glycopyrrolate will precede the action of ketamine in producing secretion. So it may dry up the secretion. Okay?
Yes, sir.
So anyway, I'll just show you a few questions like what we did in the last class. We have given you a case scenario